with congenital heart disease, severe congenital, we can expect a 1 to 2% mortality surgically. We do expect that. But 6% is still a very high mortality even in the Indian scenario, and that is what we are supposed to do to reduce it. So we should, in order to reduce this, there's two important factors which take into consideration. That is, we must stabilize the infant before we want to transport the child to a center where congenital cardiac surgery program is running, and also during the transport, he should be transported in a stable environment. So what kind of children we're going to face in our day-to-day practice which would require to a referral to a cardiac center? So there are as we know, so one would be a group which would be a duct-dependent pulmonary circulation is there, in which there is the pulmonary blood flow is entirely dependent on the ductus. Or second is the duct-dependent systemic circulation, where there's a left obstruction in the left ventricular outflow tract, whether it is due to critical pulmonary atresia or it is due to coarctation or interrupted aortic arch. So the entire systemic circulation is dependent upon the ductus. And the third group is those who are going to be with transposition physiology, where the ductus is required for intermixing is required. Then there could be a very subtle group of population which is not very commonly seen, but still it is seen, that is bradycardia due to congenital complete heart blocks. But in addition, we can have, in addition to tachyarrhythmia, what I see is congenital heart block is also quite common cause of referral. So what are just an examples of what are going to be the duct-dependent pulmonary circulations, which means that there is no flow of blood from the right ventricle into the pulmonary artery happening. So it could be a VSD pulmonary atresia, intact septum, tricuspid atresia with or any single ventricle pathology. Another group of acyanotic heart disease, which is a severe Epstein's anomaly, which presents into the neonatal period because there is the tricuspid valve is the functional RV is very small, so it is not able to pump enough blood into the pulmonary artery, as a result of which it creates a state of a functional pulmonary atresia, because initially in the neonatal period the pulmonary vascular resistance is high, so the RV doesn't have enough force to pump blood into that at that pressure in the neonate. As a result, and with the incompetent tricuspid valve, it leads to a state called as a functional pulmonary atresia, or a severe TR, which could be because of a dysplastic tricuspid valve. A similar situations can also occur with severe persistent pulmonary hypertension of a newborn, PPHN, where when the PA pressures are so high and the ductus begins to close, the RV is stunned. That is, he's not able to pump blood against that PA pressure. And for that, we need to open the ductus so that it acts as a pop-off valve. So if you see in contrast to the fetal life, this is a fetal normal. So if we see just the basic of why we need a prostaglandin is that in a normal circulation, if you see, if we see in the, this is the oxygen saturation, these are the pressures. So in the fetal life, we see the RV has around 55% saturation, LV around 65. So majority of the blood, only 10% goes to the lungs, rest passes through the ductus arteriosus and ultimate, or in the aorta around 60%, and with a 65% in the ascending aorta. So if we see a fetus who has a severe obstruction to the right ventricular outflow, like in a VSD pulmonary atresia, so majority of very less blood will be going through the ductus. Majority would be mixing up with this left ventricle, as a result of which there would be slight drop in the ascending aorta, but overall the saturation tends to be remaining the same. So what happens when this child is born postnatally? So we see that because now that when the ductus is open, still the child would be saturating around 80%. And the moment when the ductus begins to close, there is no flow into the pulmonary circulation, as a result of which all the deoxygenated blood is mixing and the saturation drops drastically to range of 50%, which is ultimately then the catastrophe of the cyanosis, hypoxia, lactic acidosis, and would all start to come. And that vicious circle goes on. So that's why we need the doctors to keep it patent, and that's how we are going to stabilize these infants by opening the ductus. Similarly, the duct-dependent systemic circulation like critical aortic stenosis, QARC, interrupt, or HLHS is there where there's an obstruction into the systemic outflow tract. So to maintain the systemic blood pressure, we need the ductus to be patent. So the child, when the ductus begins to glow, the child goes into a state of shock. And then we have the transposition where we want to have an adequate mixing at the ductal level, but majority of them takes place at the PFO level. But if the PFO is wide patent open, then opening the ductus helps a lot, especially in these TJ babies. So how they're going to present to us. So if we see to it, most of them, the cyanosis in the pulmonary where the duct-dependent pulmonary circulation is, there would be cyanosis, and hypoxia would be a dominant finding. And and usually they present in the first 24 to 48 hours of life. Whereas a systemic duct-dependent systemic circulation, they would be more because there's no systemic perfusion happening, so they will have perfusion, reduced cardiac output, and shock, and they most of them presenting in the first 2 weeks of life. So in overall, the major would be cyanosis, distress due to pulmonary edema, as in, for example, in TAPVC, obstructive TAPVC, systemic hypertension or shock or collapse would happen in patients with critical coarctation of aortas or interrupted aortic arches. So how do, because similar thing can be happening with sepsis or with pulmonary pathology, but we should have a high index of suspicion based on history, physical examination. BP measurement is quite helpful in measuring all 4 limbs, helps us to rule out children with coarctation of aorta, but then that is if the LV is not going into dysfunction. But one of the major determinants is measurement of oxygen saturation. Any child newborn who comes to the neonatal NICU, oxygen saturation will should be measured in all 4 limbs, because it helps us in not only diagnosing of cyanosis because of cyanosis hypoxia, but also it helps in like if there is a differential cyanosis is there, so we can make it out that it is because of there is a duct-dependent systemic circulation is there, or PPHN is there, or could be a reverse differential cyanosis could be there in cases, if some few conditions like TJ and with QARC. Then we have an X-ray chest, which could rule out, because we can define, as we know, the cyanotic heart diseases are of 2 types. The one, those with reduced pulmonary blood flow, and one with increased pulmonary blood flow, which helps in giving a cyanotic check, and also helps in ruling out from a pulmonary cause. And ultimately, echo is a gold standard for diagnosing. We can, based on the 2, based on whether it is child is more comfortable at rest, more suggestive of cardiac, presence of murmur, cardiomegaly, and presence of poor response to oxygen, which can further be diagnosed by using a hyperoxia test. So, which would help us in clinically making out that we are dealing with. So now then, we should our goal should be that we should stabilize this group of infants by so we should first stabilize, then try to make the diagnosis. So which would require a resuscitation with or without ventilatory support. We should if intubation is required, if there is presence of an apnea, shock, or presence of pulmonary overcirculation, as in cases of HLS or with obstructed TAPVCs is there. So the main idea is to minimize the hypoxia, which can be done by using a prostaglandin. So and after the starting prostaglandin, we should try to maintain a PCO2 between 35 to 45. This is the most important, is that we do not need, as we know, that with a duct-dependent lesion, we cannot achieve 100% oxygen saturations. And if we achieve around 75 to 85%, it is good enough. That the child, nothing will happen to the neonate if he is making a saturation above 80%. And 80 to 85%, that is perfectly a comfortable position you are in. Then you are not in any hurry, and you can easily take your time. optimizing the good fluids should be adequately maintained. But however, if we are dealing with obstructive TAPVCs or TJ, then we need to not give excessive fluid volumes also, and maintain a hemoglobin above 12. Try to maintain the acid-base balance. And in TJ babies, if the PO2 levels are less than 20 and high CO2, then it's an indication that we start with prostaglandins and do balloon atrial septostomies. So whenever you are in a doubt, you are a blue baby or a baby in shock, just start prostaglandins. There are and this has been, which was published in Circulation for the Management of Newborns with TGAs. They all say that immediately start in IV infusion of prostaglandins to maintain the duct patency. And it was found that there is no need to intubate a child, which were initially much more scared that we want to intubate a child because we were starting prostaglandin because of the risk of apnea. But then, because when we are starting at low doses of prostaglandins, there is very less chances of apnea. It is only when we are going above 50 nanograms that the chances of apnea occurs. So, this becomes a class 1 indication that you, if you are dealing with TJ, you immediately start prostaglandins. Just about the prostaglandin, we should always start with the lowest dose and gradually tend to escalate depending upon the response. As a usual dose is 0.05 to 1.1 microgram per kg. So that means, and try to maintain it at between 0.02 to 0.05. So this is just a formula which helps us in calculating the prostaglandin in a much easier way. That is, if you dissolve 1 ml, that is in 500, that is 500 microgram in 500 ml of 5% dextrose. The weight in nanograms is to 500 divided by 60 divided by 500 by 1000. It gives us what is the ml per hour. For example, a 3 kg infant, we want to give it 10 nanograms. So it comes at around 1.8 ml per hour. In microgram also, there's another formula: dissolve 1 ml in 49 ml of dextrose. And then you start at 0.6 ml per kg, which will give you at a dose of a 0.1 microgram per kg per minute. So all of us are quite worried about the side effects. Like apnea especially is a more concern to us, because, and then we want to intubate a child, and during the transport, we are starting at if the child is maintaining around 80% saturation at lower doses also, then try to keep it at a minimum dose, because it is very less common at about 0.01 microgram per kg per minute. So moment you go to above 15 nanograms, only then there are chances that the apnea would takes place. Other steps like hypothermia, vasodilatation, seizures, tachycardia, diarrhea, and sepsis, NEC, gastric outlet obstructions, only at 50 nanograms can happen. But you should be quite liberal with using prostaglandins, in the sense that, for example, those with interrupted aortic arches, you might require a very high doses like 40 nanograms, 50 nanograms, even up to 70 nanograms. One can go in these cases. So there's few cons to prostaglandins, but in addition to it, when a person doesn't know the diagnosis, it would help in establishing a diagnosis also, that if you're given a prostaglandin and the patient starts to deteriorate, so then you think that it could, and you know it's cardiac pathology, then these are the 4 conditions. It could be the possibility that is either you have a TAPVC, which is the cardiac or obstructed TAPVC, in which that is contraindicated, except in infradiaphragmatic type of TAPVC, where prostaglandins are not contraindicated. It could be with the TJ when you have a restrictive ASD, or a tricuspid atresia with restrictive PFO, or an HLS with restrictive PFO is there. So in other words, if you don't have a diagnosis, and it can help you in making this diagnosis that what you're dealing with. So in nutshell, we have to again to summarize, we have to maintain the ABCs, follow the path of the ABCs, that is airway, breathing, and circulation. That is again for airway, having optimal position, endotracheal intubation. We should have an assisted like LMAs or is available. We have should, in order to sedate, if it is too vigorous, we can just use ketamine or fentanyl. don't use midazolam in patients with cardiac cases, and use an endotracheal tube cuffed. Let the Kimberly-Clark endotracheal tube is available with those with cuffed endotracheal tube. But when you want to do it for a longer time. So as I said, we should give FiO2s, not very high FiO2s. Just give an FiO2 where we achieve around 875 to 80% of oxygen, and we can give with high flow nasal cannula support until unless we are dealing with an pulmonary increased pulmonary vascular volume, is more volume overload is happening. That is, increased pulmonary blood flow is there. Then we can use high PEEPs, and you can use invasive ventilations. As I told, for circulation, you have to start prostaglandin, limit the fluid resuscitation with volumes to 5 ml per kg. You can start with inotropes like adrenaline, dopamine, or milrinone infusions can be given. Preferably should be given by a central line, but if you don't have, it is okay to give it by peripheral line. But still, if you want to achieve a good results, having a central line is a better option. So what would be an ideal mode of transport? That would be definitely, because with the advent of this fetal echocardiography, we can almost diagnose all majority of the congenital heart diseases in utero itself at around 18 weeks of gestation, or even earlier at 17 weeks of gestation. And now we can pick it up with those hypoplastic left hearts at around 12 weeks of gestation also. So if that is the scenario, the ideal mode should be to transport them in utero, which therefore reducing the mortality considerably. If it is born, then we have to transport. We should have a good ambulance. We should transport it the personnel who has some idea of the cardiac physiology, what is happening, and an ambulance which should have a life-saving medications. This is just a cartoon which is representing what should be an ideal ambulance should have. Like, it's this incubator which is on a cushion platform, so that the baby does not get shocks while being transported, especially on Indian roads. And it should have a ventilator. Ideally, now even they have categorized these ambulances in level C or G, based on whether you have an inhaled nitric oxide inside the ambulances there or not. So I just based on this scenario, we would discuss a few cases, how we're going to be approaching to it. This was one of the case where there is a 1-day-old newborn. He was brought to us with this ECG. He had a complex congenital heart disease, and you can see there is all the number of P waves that are not being conducted at all, and there is the P interval is absolutely constant. The RR intervals is absolutely constant, but the PR interval is varying. So it was a diagnosis of a complete heart block. And it is low bradycardia. So in this case, this is although it as we know, as per the American Heart Association guidelines, if the heart rate is less than 55 in a normal child with a structurally normal heart, and less than 70 with structural abnormalities or congenital heart disease, he needs a pacemaker. So he needs a pacemaker. Definitely, there's no doubt about it. But then what the way is how to transport this child in a stable state. If the child is absolutely stable, he's maintaining oxygen saturation, his BP is stable, don't touch him, let it go, be transferred in this state as possible. If you find it is in a state of shock, you can try with drugs like isoprenaline infusion, right? But when you have a heart block, sometimes even starting these drugs also doesn't improve much. So in that case, what you can use is you can use a transcutaneous pacing can be done. Deliberately this is just our normal defibrillator, and there's all these defibrillators have this pacer option is there, and we can pace with neonates. The neonatal pads are available. We can just like we do a shock, we just apply these pads and attach to this pacemaker, and once we switch it on, then we can adjust the amount of current we want to give, starting with 10 millivolts. We start with 10, gradually escalating till you get a pacing spikes. So and this is a very easy method everybody has a defibrillator in the NICUs. One can start a transcutaneous pacing and you can achieve the heart rate maybe about 80, 100, you can keep it up. And once you have achieved it, then you are a very relatively in the safe mode. Only disadvantage is that in addition, because you're doing through the skin, so it also stimulates the respiratory muscles and skeletal muscles getting stimulated. No, not very effective, but still you can tide away with your emergency. And you can be easily be transported in this state to a cardiac center where pacemaker can be implanted later on. So this was a child who is having severe cyanosis at birth, saturation with 60%. He's intubated with FiO 200%. In ABG shows pH of 7.34, low PO2s. PCO2 was also 28. Chest auscultation revealed a great harsh murmur is heard. There's hepatomegaly, tall P waves on ECG. X-ray would show what was done, which was showing to be having a lot cardiomegaly. But if you see the lungs, it is all ischemic. So that means there's not enough pulmonary blood flow. We are dealing with a situation where there is going to be reduced pulmonary blood flow is there. This, although we did an echo which was showing a severe tricuspid regurgitation in this scenario. So even nowadays, I think a lot of people, neonatologists are also quite trained in doing a basic echocardiography. So to making out this severe tricuspid regurgitation. So now if it is a severe tricuspid regurgitation, cyanotic pathology, so that means we are dealing with a duct-dependent pulmonary circulation with oligemic lung field. So this could be either a PS physiology or severe other like Epstein's or a dysplastic tricuspid valve. So in this, what it is happening is basically because the tricuspid valve is incompetent and the PA pressures are very high. So the RV is, whenever the RV is contracting, this leads to tricuspid, not enough blood flow is going into the lungs through the pulmonary arteries. As this state, what I earlier described to be having a functional pulmonary atresia, and it can be easily be stabilized by starting a prostaglandin, and then you start on sildenafil infusions, try to lower the pulmonary vascular resistance, or if it is not working, inhaled nitric oxide can be used. So once the PVRI comes down, the tricuspid regurgitation will definitely come down. I had an experience with a preterm infant who had a dysplastic tricuspid valve, which was diagnosed in utero, and it was delivered at around 28 weeks of gestation. Was facing a lot of problems, but we continued with this prostaglandin, kept the duct patent, and started to bring the PVRI down over a period of time. And when he was around, but they had a tough time, but then ultimately, when he was discharged, there was just a mild TR was left behind. So this is another example that this is a 6-day-old term infant with severe cyanosis and distress. He was discharged by normal vaginal delivery, discharged on day 2 of life. As per parents, he was doing quite well, but then he was brought there he was cyanotic. Saturation was 60%, and on giving oxygen, it just improved to 75%. BP was 60 by 40, bilateral Krebs, but then there was no murmur and no ECG markings. So typical X-ray, what was showing a narrow vesical pedicle was there, and some congestion was there. So it was suggestive of a TGA pathology. Then to now this patient like this TGA pathology, if you can just make it out, the PFO is quite well open, and then it is quite evident. You can start with prostaglandins. It's good enough. But if it deteriorates, then and you know it's a TGA, then you can just do a balloon atrial septostomy. Now, a lot of people are doing balloon atrial septostomy and echo guided. We can do it in the NICU itself very easily. You don't need to take him to the cath lab. You can directly under echocardiographic vision itself, you can do a balloon atrial septostomy. Once the child is fully stabilized, his acid-based ABG is going fine, only then you can shift the child for treatment for the arterial switch operation, which has to be done later on. So this is a case which was that is a 9-day-old child who had respiratory distress, tachypneic saturation was 95% upper limb, lower limb was 85%. So there was a differential cyanosis was there. There was a difference in the blood pressure on the upper limb and the lower limb by 25. So that's tell us what is the importance of taking the blood pressure even in neonate also on upper. So his blood urea and creatinine was high, and he had not passed urine for 2 hours in NICU. So it was just X-ray was showing a huge cardiomegaly and some congestion. So patient differential diagnosis, but having a difference between there was a blood pressure. So this is entirely suggestive of there was a quark, which precipitated that there was a severe degree of quark, or that once the ducters begin to close. And so just starting on prostaglandin infusion, diuretic, anotropic support. I have seen once in quark, you will sometimes it can present to when you comes in a shock state. Most of us are confused with that we are dealing with septic shock, and we keep on doing on that line of management. And when we diagnose to having a quark, we just open. You will see dramatically within few hours or even 12 hours, you will feel the LV which was not functioning. There was no urine output, acidosis was there. Everything will come back to normal. His LV function will improve. He will start passing urine. The creatinine will start to fall as the ABG will tend to improve, and everything will become normalized. So one thing is normalized. Then the patient also, and you also have enough time where to refer, whom to refer, and how wherever the treatment is possible for that particular patient. So what we so what we are going to do with this neonate, if it is, although it is a ectopia cordis, not a very common which we see to routinely seen, but still this is can be seen. It can be encountered, no doubt about it. And we have so many things. Sometimes they're in news that the child has been transferred to All India Institute in the state. So how we have to transfer this group of patients? So the ideal way in this would be just to start IV fluids, cover the heart with a sterile gauge, and regularly soak with normal saline. Do an NG tube insertion, keep it NBO, give him one shot of antibiotics, and then you transfer the child. So to take him is, you have to classify the congenital heart disease into whether it is duct-dependent pulmonary, systemic, stabilize the child, and then only refer for further management. So don't be in a hurry to transfer the patient. You will always succeed in. Thank you.
Thank you, Dr. Amit Vaidwan, for an excellent presentation. It's really difficult task for management of complex congenital heart disease and its transport. You have given few guidelines for us. I think the session is now open for discussion. So those who have queries, please, you can ask.
Dr. Amitos, you can stop the share screen.
No. Yeah, I'm doing that only.
No questions in chat box.
Okay, if there are no questions, Dr. Amitos, can I ask something? The
Yes,
commonly asked question all the time, whenever this topic is being discussed, transferring baby on prostaglandin. Yeah. So, like, what are the? I mean, there are some guidelines, like the modified TRIPS score. Also, referred to it in a way, and also, what are the guidelines that you follow?
So I follow, if you are so as even in the paper, it states that if the baby is quite stable at a low dose of prostaglandins, so you're giving it even at 0.05 or minimal 10 or up to 10 nanograms, it's very rare that he will go into apnea or any side effects of having a prostaglandin. You can easily transfer him on a nasal oxygen, and it can easily be done. Only when we are going at a very high doses of prostaglandins, for example, 15 micro, and this was a publication also which was published at what doses the incidence of apnea increases. So it was found that when it is around 15 nanograms, when you're going above 15 nanograms, it is only then when you have chances of apnea. But even then, if the child is not apneic and you are comfortable, I think you can easily transport the baby, and the person accompanying he can intubate. But if you feel that if the child is on a very high dose of prostaglandins and the person who is accompanying cannot intubate, it would be better to intubate and transfer it.
No, the specific question would be like, suppose the baby is usually we suspect initially, if at all you don't do functional echo and all, the usual way you suspect is probably when you see a baby without distress and poor saturations. A baby who has distress and is already on, say, CPAP, such a baby, would you intubate and transfer, or would you just continue with that? Because even if the prostate dose is something like 10 or 20 nanograms only.
Because of prostaglandin, I would like to intubate in this child. If the child is an overcirculation is happening, so that is dealing with an overcirculation.
Have we lost you?
I think so.
Okay.
There is some connectivity issue.
Wait. Throughout the presentation, his connection was a bit less because connectivity was not good.
Okay, while we wait for him, just for the, I think if at all there are PGs and fellows in this, the TRIP score is the one that has been developed and validated by the Canadian group, Lee et al. First in 2001 and then subsequently version 2 in 2013. And actually it takes into consideration only 4 parameters: temperature, blood pressure, respiratory status, and response to noxious emission. So it is not, he was mentioning the low, high score in babies who are transported without proper this thing. But it's a general score, but that gives a lot of information. And one of the questions that is always asked is this: are we getting him back? Somebody can.
Not yet.
Pavan, അവരുടെ PRO ഉണ്ടായിരുന്നല്ലോ.
Yes, Mr.
Rashid.
Devi Krishnan, I think Devi Krishnan is here. Can you please check?
Rashid asked.
Devi Krishnan, can you please check?
I will check, sir. Just a minute, sir.
1 minute, sir. I will check.
Just not to lose the continuity, again, I'll just bore you with the very, very basic concepts for those who are very, very new to this. When do you suspect cardiac disease? Again, right in the delivery room, when you are rustated the baby, or rather when you are doing the NRP, and then you find that baby has no distress but poor saturation. So these are the babies whom you had to use oxygen. Oxygen use in delivery room is very, very limited now. You just use it only when baby has no distress but poor saturation, means not even 60, that is at the time of birth. So in such scenario, baby subsequently after you bring to an ICU, put on CPAP, and then you still baby doesn't improve. So distress may not be the important sign. Respiratory distress present and baby cyanotic, still you would suspect respiratory cause. Only where distress is not the important sign, but desaturations or low saturations is where you suspect. And he very clearly said that, I think that message has to again go. The saturation target should be 80 to 85, not more, when you use oxygen in these babies, because you are you don't know until you, of course, do your echo and you know what is the problem.
Yeah, exactly, sir. This is what it is. Regarding your question,
please go ahead. I'm just filling the gap for you.
I feel so. It is not because when you're on a low dose of prostaglandin, you need to ventilate the child. It is because you're going to support the myocardium, heart with ventilation. that's why, transporting that group of children who are with respiratory distress, plethoric lung fields, these are a group of children where ventilation would definitely be helpful in intubating.
Yeah, probably one more thing I would like to add is that if you start prostaglandin, even if it's a high dose, above 50 nanograms, you wait for 3 to 4 hours because the chance of apnea is high in the first 3 to 4 hours.
Yeah,
Maybe it
that's
didn't
true.
give you respiratory distress in the first 3 to 4 hours, and if you can come down on that prostaglandin to 30 to 40 nanograms, I am telling about duct-dependent systemic circulation, that is intertriatic Coarctation or something like that. They can come down on the prostaglandin, and after 3 to 4 hours or 4 to 5 hours, I think you can safely transport to a cardiac center.
Yeah.
There's some question in the chat box, I think.
Yeah. Is differential saturation significant at less than 24 hours of age? That's one question.
See, basically, differential saturation is what telling us that either we are dealing with a condition where the ductus is open and the PA pressures are very high. So it is shunting its right to left is happening into it. So either we are dealing with either a PPHN condition we are dealing with, or we are dealing with an interrupted aortic or critical coarctation, where a duct-dependent systemic circulation we are dealing with. This holds true even in whether it's in the first 24 hours also. There's nothing like that.
There is one more question. Is it okay to start prostaglandin in all cyanotic congenital heart disease? From Ambili Varghese.
I would say yes. If you don't have echo which shows that it is contraindicated, I would say start it. Because not starting prostaglandin will cause more harm rather than starting prostaglandin.
Mitos, I have one question for you. That is, you told that in obstructive TAPVC, in infracardiac obstructive TAPVC, the prostaglandin is not contraindicated. What is that rationale behind that?
The rationale behind it is because here where we believe that when the all four pulmonary through the draining at the level, so to keep the ductus venosus open, make it an unobstructed type of TAVC where we are starting prostaglandin, trying to relieve the site of obstruction, so trying to make it an obstructed TAVC. So this is what that's why we are starting prostaglandin in front of TAVC.
No, I didn't get that. Your voice was breaking. To keep the ductus venosus patent.
Okay. Yeah. Okay. Because ductus venosus, more delivery happens. The ductus venosus.
Go on.
Yeah.
Connectivity issues ഉണ്ടെന്നല്ല.
അതെ.
അല്ല, ഡക്ടസ് വിനോസസ് പേറ്റന്റ് ആയിട്ട് നിർത്താൻ വേണ്ടിയിട്ട് സ്റ്റാർട്ട് ചെയ്യുന്നു എന്നല്ലേ പറഞ്ഞത് അല്ലേ?
Manoj, unmute.
Yeah, the thing is any this thing you may not be clear of the physiology. So probably you start and if baby deteriorates, then you stop. That's what you do, because it's not very clear, because I don't think all babies it's safe to start in some of the babies it may still that's what probably he's trying to say.
No, if you are diagnosed with obstructive TAPVC, then why you start prostaglandin?
No, you may not have the diagnosis at that point. Just because he may be having some feature suggestive of obstructive this thing, don't hesitate to start. You start, baby deteriorate, stop. That is what generally is recommended.
That's what it is.
Yeah.
It is only inside the infradiaphragmatic. Why it is starting is because if you see the anatomy of how this is happening is there's all four pulmonary veins. There's a descending vertical vein coming down and joining at a point of portal where the portal vein comes. So the obstruction it has that level. So if we try to open the ductus venosus, the site of obstruction which is causing in infradiaphragmatic, that is deep. So in other, we are trying to make an obstructed TAPVC into an unobstructed one. So which is very, and if you see an unobstructed TAPVC child, neonate, he's absolutely stable. He's maybe mildly tachypnic and desaturating, except that nothing would be there. And that's why we do even a surgery at around 6 weeks of life, whereas an obstructed one becomes an emergency.
So even if obstructed, will it work?
But if you, for example, if it is a supracardiac TAPVC, you're going to start prostaglandin, then the child will deteriorate. This is how you will come to know, until unless you have an echo. If you have an echo and you can make diagnosis of infradiaphragmatic, you can start it. Otherwise, you don't start it.
Okay. One more doubt. You are told about this transcutaneous spacing, isn't it? That you are a defibrillator machine using for transcutaneous spacing. So how much time, if you pace the baby, how much time will it last? Because before you transport the baby, you suppose you pace it.
You can transport. You have to see. This is the disadvantage with pacing is. Because once you start pacing now, the child's heart becomes dependent on that pacing. Then weaning the child from the pacing mode is entirely very difficult. So it is always a bit better to not even we also. If the child has come very late and we want to do it next day and the child is stable, we will do it. Don't touch it. We're not going to put an temporary pacemaker also in that group of child, because once you insert a pacemaker in a heart block patient now, the child becomes pacemaker dependent. So it is better if the child is stable, it's okay. But otherwise, you have to transport with that transcutaneous pacing only.
Okay.
This is for you to, this is for anybody to gain time. If the child is deteriorating, he's going to shock, his blood pressure is not maintained because of heart block, the cardiac output is not sufficient, then we can bail out by this method.
Okay.
And then neonatal pads are available with that. Our temporary pads are available, which last for around 24 hours with that.
There is a beautiful question in the chat box by Dr. Sanjeev. Basic concept question.
If you put the child on oxygen, which is duct dependent, deteriorates, and if we stop the oxygen, will the child improve, or will we get time to transfer the child?
Definitely. So giving oxygen in a duct dependent child is lethal. We're trying to, because oxygen will try to close the ductors. So that's why we don't, the concept that keep on doing FiO2s very high is not, that's why recommended. We want to keep it a minimal so that we just keep it around 80%. That's why we are dealing with this thing. And once you if ductus is open, sometimes see, because of the, if you see the neonatal physiology, what happens in patients with TGA, because the ductus is receiving more oxygenated blood with pulmonary atretic child. So the smooth muscles are very, not very hypertrophied in the ductus. So the God has made it like that the ductus doesn't close very quickly in a cyanotic child, and giving us time for that.
Just to add on to it, actually,
so you should not.
Please go ahead.
Right, sir.
What I would request everybody to remember is neonatology is not always black and white. There are lots of shades of gray, and now you are thinking of, in such a scenario, you are thinking about protecting which organ first. So using oxygen to maintain any saturation more than 80 to 85 is definitely a crime. But then using, if the saturation is too low, there are other organs like your brain, they are also going to be this thing. So heart is not the only organ. So probably we need to strike a balance, use the minimum, provide adequate ventilatory support. So all the time, even if the baby has congenital heart disease, that may not be the only problem. As we just said, respiratory distress is more due to other causes. So optimize that, and still if you find, then only use oxygen, and then of course target should be that. Is it okay?
Definitely. That's why this targets have come up with 80. because they found that the brain injury doesn't happen that with those saturations. Because even if you, whatever you do now, sir, in any case of stenting, you do a beat, you're going to achieve a saturation of 82% only.
Correct.
Even with even with interventions.
Is there any more questions? I think there is no more questions. Thank you, Dr. Amitosh. It was really a wonderful session and a good interactive session. Now I request Dr. Manjusha to officially propose vote of thanks.
Thank you, sir. It was a great evening today with the installation of the new office bearers of TNF and a great talk by our respected speaker, Dr. Amitosh Singh Vaidwan. So it was a light thrown on the various nuances of the critical aspects of neonatal cardiology. Thank you, sir, for your valuable time with us today. I also thank our NNF Kerala State President, Dr. VC Manoj, who is a torchbearer and a guide for all activities related to the Neonatology Forum, both in the state and in Thrissur. Thank you, sir, for being with us and guiding us today. I thank our past Vice President of South Zone IAP, Dr. Andakeshwan, for his felicitations for today's program and his best wishes for the upcoming team. I thank Dr. Ravindra Verma, our presiding officer for the elections today, for the smooth conduct of the elections and unanimously selecting the office bearers for the next term. The immediate past president, Dr. Murilaj, needs much kudos and applause for his great work of 3 years for bringing up and putting together TNF and for the great path he has shown as office bearers. And we hope and wish to keep up the name of Thrissur Neonatology Forum and carry on the activities that he has initiated. I also thank the new president and wish him all the best, Dr. Rajagopal. Sir, I'm sure we'll uphold the activities that TNF has been doing all this while. And Manoj, sir, we hope the team can live up to the expectations that you have from us. I thank Dr. Pavan, despite his very busy schedule within IAP, IMA, and NNF. He's one person who is always there. So we as a team hope we'll take this forward again. And last but not the least, I would like to thank all the members of NNF Thrissur, of the TNF family, for being there today, for joining us even in this difficult time of COVID. And we hope and pray that you all support us in all the ventures that TNF and the new team has got to put forth to you in the coming year. Thank you so much. Wish you all a good night. Thank you.
Thank you, Dr. Manjusha. Anyway, we will try our best to come out with more clinical meetings as well as CME programs, because we know that it's very difficult task still, because we have a very good team here. So once again, thanks to you all. The CME session is closed. Thank you.
Thank you so much. Dr. Amitosh, it was an excellent talk. Brief, but everything covered. Thank you so much.